All right. Good morning, everybody. My name is Viral Patel. I'm happy to introduce our next speakers. This is going to be Dr. Bischoff from the University, from Ohio State University, and Dr. Pettit from Indiana University. They're going to be talking to us about oncologic emergencies and the curricular issues associated with that. So without further ado, I'll turn it over to you guys.
Thank you very much, Dr. Patel, for that introduction. As he was saying, we're hoping to hopefully elucidate a problem with our current education system as it relates to an important subpopulation, those folks with cancer presenting to our emergency departments. Guess we have to start by saying we have no disclosures. Of note, this talk was sponsored by SAM's Oncologic Emergencies Interest Group. And these are objectives for today. Firstly, we like to review the current trends in patients with cancer seeking ED care. We're going to ask ourselves what ED providers are expected to know. We're going to do this by taking a look at the ABEM model of clinical practice, which is basically what we're tested upon once we become board certified. And then lastly, we're going to describe the educational gaps related to oncologic emergencies associated with current immunotherapy, which is one of the major gaps. Just want to make the point that immunotherapy is not synonymous with chemotherapy. And we'll kind of get into that a little bit later. So let's take a look at the current state of unscheduled acute care, namely the care of cancer patients or patients with cancer in the emergency departments across the country. This analysis was done by folks at the National Cancer Institute, or NCI, and it was published in 2017 in JAMA Oncology. What they did is they took a look at the NEDS data set from 2006 to 2012, and that's the nationwide emergency department sample. And they found that there were 29.5 million visits by patients with a cancer diagnosis in emergency departments during the study period, roughly 4.2%. So that's 1 in 25, 1 in 20 patients, which for the average ER physician, that means 1 a shift. Importantly, this was done between 2006 and 2012. We can expect that this number is even higher today as the population ages and our cancer treatments and therapies become more efficacious. We have more people living with cancer, living under current treatment and surviving cancer. This population also was admitted at 60%. Which is pretty high, especially when we compare it to patients without cancer, who are only admitted at a rate of about 16.3%. Suggests one of two things. One, these people are very, very sick when they come to the ED and require intensive resources and hospitalization. Or two, maybe we are not as equipped as we think we are in handling this important population. As I mentioned, most of us are seeing at least one of these patients per shift. So to answer those questions, we have to look at what we're expected to know. So we'll do this by taking a look at the 2016 ABEM model of clinical practice. So what I have up on the screen right now are the 20 different categories that were tested upon on the in-training exam content. If you'll notice, out of the 20 categories, there's no oncologic category. Does that mean cancer is an important part of our skills? Not necessarily, but it's at least not recognized as a major category on the 2016 model. Fortunately, when the 2019 revisions were made, there were some significant changes and clarifications, namely the addition of and modification of category 8 to the hematologic and oncologic disorders category. And you'll see here the subcategories within there. So things like febrile neutropenia, hypercalcemia, SVC syndrome, tumor lysis syndrome, things that I would argue most ER physicians feel confident in treating. Now the question is that actually true? We'll take a look. And the other thing that's I would argue is missing here is any category relating to immunotherapy. And Dr. Pettit in a little bit will be explaining why that's an important omission. Also of note, the 2019 model will begin testing in 2022. So we got a couple of years to get us up to snuff before we have to address those categories. But as I was saying, most EM physicians which I would argue, feel confident in treating febrile neutropenia. But is this actually true? So this is a survey that was done at an academic center in the Northeast that was affiliated with a comprehensive cancer center. So if we're looking at people who should be the most competent at treating febrile neutropenia, this is probably the group, and this data probably represents the best case scenario. Looking at this, we can see that among those surveyed, only about a quarter of ABEM physicians were familiar with national guidelines as it relates to the management of febrile neutropenia, namely the MAS score, which is the Multinational Associations for Supportive Care in Cancer Risk Index score for the management of febrile neutropenia. And this score was created in 2000, so it's been around for 2 decades. What this score allows you to do is risk stratify patients with febrile neutropenia to either inpatient or outpatient management. We can see that in the high-risk scenario, so essentially the people who are in septic shock, as ER physicians were very aggressive, which is in concordance with the guideline care. When it comes to the low-risk sample, which is a population that could potentially be discharged on oral antibiotics and fall as an outpatient, we do a less than ideal job of identifying these patients, suggesting that there might be an education gap in the management of a topic, febrile neutropenia, that's been in our model of clinical practice for quite some time at this point. So if there's an issue there, can we look to the literature to see if there's any guidance on how to treat this and whether or not, as a field, emergency medicine is really paying attention to this important subpopulation? When we look at Annals of Emergency Medicine, we can see that ever since 1979, if we search for either oncology or cancer as key terms, there's been 60 publications. Unfortunately, about half of these were abstracts, so about 30 abstracts. When we look at AEM, we find a similar problem or issue, about 66 publications from 1995 until 2022. So there's a little bit of literature there, but the lack of hits on these searches suggests that we could probably do better, and this is an important area for us to continue to do primary EM-based research and publish on. Fortunately, as a field, we are starting to recognize this, and I think this is exemplified by the Journal of Emergency Medicine, who actually created an Oncologic Emergencies section within their journal. And I also have to mention that journals like WestGem and the American Journal of Emergency Medicine have published case reports and other primary manuscripts on the topic of cancer in the emergency department. So now that I've kind of set the stage of what our current trends are and where the current knowledge base is, I'm going to hand this presentation over to Dr. Pettit to kind of go into the more specific curricular gaps.
Thanks, Dr. Bischoff. So I'm going to focus on immunotherapy as a gap within our current model, and then I'll introduce a couple of other topics near the end of the talk. Immuno-oncology therapy is really becoming one of the mainstays of treatment for patients with cancer, and this really encompasses a large host of different drugs and therapies, many of which are very new and novel. This includes antibodies, viral therapy, various cytokines and vaccines that really, they target the cancer cell with a novel mechanism. And this technology is pretty new. We're really looking at the green timeline up above, where the targets for these drugs really were discovered and characterized in the late 1990s. And then it was in the mid 2000s, around 2011, when the first, what's called a checkpoint inhibitor, it's one of the different types of drugs, was actually approved for melanoma. And this, since 2011, these drugs have exploded on the market. There's a huge demand for them, and new drugs are approved and available almost every month by the FDA. This culminated in actually the Nobel Prize in Physiology and Medicine in 2018. And these are two immunologists that really were the pioneers in identifying these targets. And because of that, and because these drugs are so good, they were awarded the Nobel Prize. And I would argue that these drugs are not really well characterized and studied within the emergency medicine literature. And despite that, these drugs are amazing drugs. They have demonstrated great efficacy for the treatment of patients with cancer, compared to traditional cytotoxic chemotherapy, which is the dark blue line. Various combinations of the drugs, and this is just one of many different curves that demonstrates the great survival rate of these patients that receive these drugs. And so to kind of highlight that, we emphasized this before, but really to understand that immunotherapy is not chemotherapy. Traditional cytotoxic chemotherapy tries to kill the cancer cell. Immunotherapy tries to turn on your immune system to kill the cancer cell. And this is a huge distinction, which is not really in our current curriculum. And that's despite a recent survey from just a couple of months ago, where EM trained physicians, residency physicians were surveyed on their awareness of oncology topics. And 91% of patients in that first survey demonstrated that oncology topics are critical in the preparation of EM physicians. We see these patients every single day. Around 65% of these patients or these participants, though, said they only 65% feel that they're adequately trained for the treatment of oncological emergencies. And I think most striking and most notable is, despite the birth and the explosion of these drugs, only 17% of programs have introduced immunotherapy and its adverse events within their curriculum. And that's what we're getting at today, is we want to introduce these drugs as being very important for the treatment of patients with cancer. This is a retrospective cross-sectional study published in JAMA a couple of years ago now, and they basically looked around 10 years ago what percent of patients would have been eligible for checkpoint inhibitors, and that was only 1.54%. That's really when the first drug came out for melanoma. Fast forward to 2018, only 7 years later, 43% of patients would be eligible for checkpoint drugs. And this is only seems to reason that these numbers will be higher today, given the more drugs that are approved. And so I'm sure the immunologist that won the Nobel Prize would really want us to focus on the mechanism of these drugs. The truth of the matter is, at 3 in the morning, we don't really care about PD-1 antibodies and CTLA-4 antibodies and CAR T-cell therapy. We need to know they exist. The exact mechanisms are quite complex and challenging. But being aware that these drugs exist is a huge first step for emergency medicine physicians. There are 5 different classes of immunotherapies, and this is for over 20 different cancer types. And this is about a year old now from cancerresearch.org. And it seems to reason, again, that these class of medications only has expanded since then. From that 2019 survey, this is a very short list of checkpoint inhibitors that are approved for various cancers. And you can see there's a whole host of cancers, between GU cancers, Hodgkin's lymphoma, lung cancers. And so these drugs are used for a wide array of different malignancies. So much so that I get weekly, monthly emails of new drugs that are approved for the treatment of various cancers. And it would be nearly impossible for the emergency physician to keep track of which drugs are approved for which cancers, but to recognize that these MABs and MIBs are approved for the treatment of cancer, and we're going to see the patients presenting emergently to our emergency departments. So how do these patients present? The top of the slide, it's the one of the droids from The Mandalorian, and his kind of quote during the series is, "I will initiate self-destruct." And that's basically what the side effects are of immunotherapy. The drugs activate your immune system to kill the cancer cell, but in turn, they can cause some autoimmune conditions, which are some of the mainstay side effects and adverse events that we see, such as pneumonitis, colitis, gastritis, some very weird things too, like type 1 induced diabetes and Guillain-Barré. Depending on the different drugs, different side effects that we experience on the frame on the right, various side effects are more common, and some of them have higher mortality. So for example, the myocarditis, you can see if you experience myocarditis due to a checkpoint inhibitor or immune therapy related adverse effect, has really high mortality. And the novel part of these drugs is it doesn't matter when you take the drug, you can experience a side effect on the frame on the left weeks to months after the treatment of that immunotherapy. And so you have to be on the lookout through the patient's charts to say, hey, look, what were you on? Why are you on it? Oh, this was immunotherapy. We need to be watching out for very novel side effects. And we're fortunate that many societies have already given us the guidelines how to take care of these patients in the emergency department. We aren't alone in this field, and so adopting the clinical practice guidelines by various other societies will be, I think, key for emergency physicians. And again, recognizing that these exist is really important. But to the exact challenges that we face at 3 in the morning for these patients with cancer on immunotherapy, this was actually a case report that I saw at the beginning of the pandemic, where we had a guy with stage 4 lung cancer on an ALK inhibitor and came in with fever and cough. Nowadays, we'd be like, oh, well, this is COVID. A year ago, we didn't have rapid COVID testing, and this guy was on immunotherapy. He ended up getting admitted to the hospital, got put on high-dose steroids, which is one of the mainstays of treatment. He got a bronchoscopy, ended up having COVID-19, which was a send-out lab at the time. But this is kind of an illustration that in the moment, diagnosis of immunotherapy complications is quite challenging. And typically the oncologists talk in grades, which is something we typically don't do in the emergency department. There's different grades, there's different spectrums of these side effects. And depending on the grade or the spectrum, kind of dictates how we manage these patients. Again, this is something that is not within our curriculum, but I think recognizing that these exist for all of the different side effects is a huge first step of the training for the emergency physician. So while immunotherapy, I think, is going to be one of the mainstays of things that we need to address as we go forward, there were a couple other small topics that I want to introduce in addition to immunotherapy, things to think about as we move forward. And these are kind of two topics of the patient with cancer, before they're diagnosed and then after they're diagnosed. How do we manage these patients? How do you manage the person with new onset cancer in the emergency setting? Do you admit them? Do you not admit them? Do you have them follow up? We don't really know how to exactly manage every one of these patients, and every place is different. There's a lot of evidence that suggests that discharging patients with, here's an appointment for a follow-up for your cancer, among Medicare beneficiaries, patients don't follow up, and that's associated with high mortality rates. Similarly, what about end-of-life care? Palliative care is a huge and important field that can provide a lot of great benefit to our patients. And how do we manage end-of-life care in the emergency setting? This is something we do every day. I did it last night. And so how do we take the skill set of a palliative care physician and integrate it to emergency medicine? The communication skills and the ability to care for these patients at the end of life, I feel, is a very important topic as we think forward. So in conclusion, I think there's a couple of areas that we need to focus some research on: is transitions of care. How do we take care of immunotherapy complications? How is COVID-19 affecting all of these issues as well? And then further supplementing, we have a couple of groups specifically with our SAM Oncological's emergency interest group is developing the curriculum, improving residency education, educating active physicians who are in the community who don't necessarily have the opportunity to be re-educated on immunotherapy within their residency program. And so I think all of the issues taking forward, we have some opportunity to improve the practice and the care of these patients. And that really starts first with education. I think with that, we'll conclude our talk, and we would appreciate any feedback or comments or questions. And thank you so much for coming.
Hi, my name is Mary Kate. I'm a PGY2 at New York Presbyterian. I actually have a decent amount of interest in oncologic emergencies, and particularly have been trying to start a project in like CAR T cell side effects, and have approached and spoken to like heads of oncology at both our campuses, Cornell and Columbia. And while there is some interest in like a multidisciplinary project, I do get a little bit of pushback where oncologists seem to want their patients, probably like reasonably so, but to avoid the ER, and they would prefer to route them like from clinic to inpatient. And so I'm just wondering if any of you have had difficulties kind of collaborating with oncologists on projects like these, and if you have any suggestions on how to move those projects forward.
I can give you a very specific anecdote of my experience. So I'm a new faculty at Indiana University. We're at the NCCI Comprehensive Cancer Center, and we have a lot of ongoing clinical research. We have a lot of funding for it. As part of my appointment here, my job is to be the cancer ER doc. There's nobody in our department doing this. In my first meeting with one of the medical directors of the cancer center, she basically said, "Stay in your lane.
Right.
You don't see these patients." I think Dr. Bischoff kind of illustrated, we are seeing these patients, and we see these patients a lot. And so kind of two things is you have to find other people within your department, whether it's emergency medicine, whether it's internal medicine, whether it's the cancer center, that can advocate that this is actually an issue. Because one or two people that you talk to, they may be very against you taking care of their patients. But the truth is we are taking care of them. And starting the conversation of, this is what I'm seeing in the department. This is what I want to do to improve it. If you'll get a few people on your side that can help mentor you through that. It's very challenging. I've been here now 2 years. I'm just now getting some good mentorship of people that are like, yeah, why don't we look into this in the emergency setting? And it's very challenging.
Right. I'm just kind of keeping my eyes open and looking for CAR T cell patients just as they come into the ER, but I feel like that's not super fruitful.
I think kind of to your point though, it sounds like mentorship may be a big thing that you need. A couple of things that maybe I could encourage you to do is we do have that interest group, and we do have a lot of available mentors through our interest group. We're actually meeting this afternoon.
Yeah, I was going to come to that, I think.
Perfect. So I don't know if Jason has anything else to add.
One other important thing to note is NCI is very interested in the interface between the ED and the oncology treatment paradigm. They actually had a summit earlier this year to how to develop that workforce, whether that's coming from the EM side or from the oncology side. So it can be very discouraging when you're trying to do something new. I would recommend that you keep at it. You'll be seen as somebody who is ahead of the game in 5 to 10 years. And if you kind of point to NCI's notice of special interest and the funding associated with that, that might get your oncology colleagues to at least pay attention.
That's a good idea. Cool, thank you guys.
But this that statement gets back to the role of emergency medicine. And it's not just the oncologists who need to recognize the role of emergency medicine and the treatment of patients with cancer, but it's also for us as well. So we need to start recognizing and paying attention to guidelines that are created by ASCO or the American Society for Clinical Oncology, for example, the MASC tool, and really start taking that into the REDs and applying those guidelines.
Right.
That was really enlightening. Thank you very much, guys. Does anyone else have any questions?
Hey, this is Mark Courtney. I've got a super quick question, and I kind of logged in maybe 3 or 5 minutes after this started, so you may have answered it. Is anybody working on anything better than the MASC or the Talcott criteria for febrile neutropenia? I mean, these are old prediction tools that have not really taken off or gotten a ton of utility. Is there anything else on the horizon, better?
So CISNE has been studied in the ED for solid tumors and shown to be maybe better than MASC. The benefit of MASC is it's not just solid tumors. Beyond that, I'm not familiar with anybody doing new investigation to that. To be honest, febrile neutropenia is an important presentation, but as immunotherapy takes over, we're going to see less and less of it.
I also think to that question, Jason and I are trying to get a paper published specifically on that, on patients at Indiana University, and the overall prevalence of febrile neutropenia in the grand scheme of things is so low. For example, at our institution over 5 years, we had 200 cases. And so either these patients are being managed before they get to the emergency setting, but I think that the true prevalence of these is so low that is it worth the time? I don't have the answer to that. I personally haven't seen febrile neutropenia in 2 years, and I work at a comprehensive cancer center. So it's kind of to your point, I don't know if there's anything else, but the question is, does there need to be? And I think that's a question that's really unanswered right now.
Yeah, and then that kind of leads me just to another kind of, this is bigger and open-ended, and we can maybe tackle this in the afternoon, perhaps, but is there an acute care research agenda that you guys are working on, or that could or should be worked on? I mean, the subject of this didactic was curriculum, and there's a lot of room and all, but I am curious kind of, where the dialogue is on that.
Yeah, so the reason why this talk is on curriculum is because education is how you're going to develop your workforce who's interested in the topic to start doing the research. There is the Concern Network, which is an NCI sponsored but not supported research network. They've published some work, and they've got a website if you search Concern Emergency Medicine to kind of give you a sense of what the current research agenda is. But as far as acute care goes, there are a number of topics, whether that is new diagnosis, improved implementation of national guidelines, transitions of care, palliative care. Unfortunately, as a field, we've kind of gone off in different directions and haven't really focused too much to really create one mission forward. To some degree, NCI's meeting earlier this year is trying to reestablish a research mission in this acute oncology care. Basically an update from what was published by Jeremy Brown, I think 5-10 years ago.
Also, my mentor, Jeff Klein here at IU, he likes to remind me that emergency medicine is one of the lowest funded NCI fields. And at this point, up till this year, there's been absolutely no funding within emergency medicine in the realm of oncology, oncological emergency problems. And so there was just now that notice of special awards earlier last year that's really starting to tackle the interface from these. I think the NCI is becoming more aware, and it's a matter of targeting our research with their goals is going to be the first step for this next 1 to 2 years.
Awesome. Thank you very much, guys. Appreciate it.
We appreciate everybody's interest. We're happy to answer any questions. Feel free to shoot us an email.